VentRounds. This is a recorded session. I am your host, Rob Chatburn. Dr. Mireles is not available today. So today we're going to talk about a particular form of volume control ventilation where people use a descending ramp. But before we get into that, I want to present our disclosures. There's not going to be any endorsement of any mode or any manufacturer or company. What we say is our opinion. Does not necessarily represent that of the Cleveland Clinic. This is my disclosure. I'm a consultant for various industries, and I get fees and royalties from books. Dr. Mireles also gets fees and royalties from books, and we are co-owners of a patent, and we're consultants for Ingmar Medical. Ground rules. This again is a recorded session. Keep your microphone muted. We may call upon you to comment. You can always comment by putting up your hand or putting a comment in the chat, and we'll call on you there. If you enter your name, if you're a respiratory therapist, you'll get CRCEs. Remember that the evaluation must be completed to receive the credit. Okay, let's begin. On the left-hand side of the screen, we see idealized waveforms for volume control with a descending ramp inspiratory flow waveform. I find that this is very common amongst respiratory therapists, not just here, but it seems to be all over the United States. When I ask them why they do it, they frequently say that it's a more physiologic flow waveform. Well, that's, I think, a misunderstanding. People don't breathe in straight lines. They breathe more like sine waves. And the way you can prove that to yourself is just watch the flow waveforms for a patient that's in CPAP or in PAV or NAVA. Those are more natural waveforms, and they look more like sine waves. But at any rate, there are some interesting characteristics of flow waveforms when you use a descending ramp. And again, the way we orient this is that if you look at the pressure waveform, it can have a variety of shapes depending on the relative values of the elastic load and the resistive load. So in this case, on the first waveform, we see an increased resistive load. And because the flow is highest at the beginning of the inspiration and volume is essentially zero, almost all this pressure is just due to resistance. It's just due to resistance times flow, which comes right out of the equation motion down here. And then as flow descends, volume increases, then the pressure due to the elastic recall, shown in blue here, gets higher and higher until end inspiration. And in this case, flow is set to be zero at end inspiration. And at that point in time, the only pressure that's there is the elastic load. In other words, that's the plateau pressure. And we can prove that by looking at this breath here, which actually has an inspiratory hold. And we see that when flow is zero, you get the plateau pressure, just as you would if you had occluded the airway. In contrast, if you have an increased elastic load, the initial pressure rise is more normal because he has a more normal flow resistance. But as volume increases, the elastic load, the elastic pressure drop increases, so that at end inspiration, we have a much higher plateau pressure because the elastic load is higher and the compliance is less. So the interesting thing about using a descending ramp like this is that you can, if you don't have an inspiratory hold, you can just see at a glance over time what's changing, resistance or elastance. And if you can just freeze the screen without freezing with the ventilation, you can see what the pressure is at end inspiration, and that'll be a pretty good approximation of plateau pressure. We want to measure plateau pressure all the time. We want to keep it less than about 30 centimeters of water pressure. But unfortunately, in the patients that are the sickest, where we want to get these plateau pressures, they oftentimes can't tolerate a long inspiratory hold because they become hemodynamically unstable. So this is just a shorthand way, if you will, of getting plateau pressures and seeing the relative contribution of resistance and elastance or compliance to the pressure waveform. Okay, so we start in with our case today. What I'd like you to do is look at this for a moment and see if you can give us a tag. Ariel, can you take a look at the chat for me? Okay, we got volume control, CMVS. This looks good. So, what we see here, we have volume control. We have continuous mandatory ventilation. And this is simple set point targeting. We don't see any spontaneous breaths happening here. In fact, we don't see any patient-triggered breaths at all. So it can't be, according to this data, any form of IMV. Okay, so now having given us the tag, what do you think the load is for inspiration and for expiration? Keeping in mind what we said before about the expected wave shape of a descending ramp waveform. We see comments here that we have an elastic load. Yes, you guys are all getting it. The elastic load, the tip-off is that the end inspiratory pressure is much higher than the initial pressure rise. We have elastic load both for, we can see that from the shape of the inspiratory pressure waveform, but we can also see it if we look at the time constant here, right? The time constant on the expiratory flow, this is a passive exhalation. We see that it's a very short time constant. And 3 time constants looks like about a second. So a short time constant means low compliance or high elastance. So we have elastance as the elastic load for inspiration and expiration. Now, do we see any evidence of PMUS anywhere? What do you guys think? No PMUS? Very good. Do we see anything that looks a little suspicious in the flow or pressure waveform? You see these little perturbations here. You see that? See that? See that? See that? They're all over the place. So we'll come back to that in a second. Do we see any evidence of patient-triggered breaths? What do you think? Yes or no? Now, this is a servo ventilator. We have a comment of cardiac oscillations for these little perturbations. That's good. We don't see any evidence of triggering either by pressure or by flow. This is a servo, and it would change these curves to white if there was any patient triggering. So we can't say that there's any trigger discordance, right? Because there simply is no signal for the patient. So there's no trigger discordance happening here. What about for inspiration? Would you call this assistance, over assistance, or under assistance? We don't have any clinical data on this patient. So we'd have to assume that it's either a paralyzed patient who is being assisted appropriately, or if this patient had a high pH, possibly oversistence, right? Can't tell without any further clinical data, but that's a possibility. It wouldn't be under assistance because then we'd see evidence of PMUS in the patient trying to make inspiratory efforts, and in this case, that would deform the pressure waveform. Okay, cycling again. In order to say that there's any kind of discordance, we'd have to see some sort of patient inspiratory or expiratory effort. We don't see any, so there can't be any discordance. So we could possibly just call this a normal ventilatory pattern. Yes, go ahead.
Just a comment. Since this is a servo U and we can manipulate the descending angle not to be a fully descending ramp, this one doesn't reach the zero baseline before the end of the I time. So the end time was manipulated. So in order to see the pressure plateau on this one, do you believe we have to make an inspiratory pause?
Very good point, Ariel. I don't know why some people change the end inspiratory flow from 0 to anything above 0. It doesn't make any sense to me. But the point is, because you still have flow at this point in time, then this pressure no longer represents plateau pressure, right? Because if you were to drop the flow, the pressure would drop and we would see a plateau pressure like that if you extended a short period of 0 flow. Very good point. So the idea of looking at this end inspiratory pressure and saying that's plateau, it's only valid if the flow goes down to 0, and that's entirely a function of the clinician's setting on the servo ventilator and other ventilators as well. Good point, Ari. So let's get back to expiration. And in the expiration, this is where we see no evidence of an inspiratory or expiratory effort. You see the short time constant, the fast expiratory flow decay back towards the 0. But we see these little perturbations, which someone pointed out might be cardiac oscillations. Sometimes cardiac oscillations can cause a problem, right? Because they can cause a false trigger signal. But in this case, what could we do to distinguish what's going on here a little bit better? Anybody have any idea? What maneuver could you do at the bedside to help us out? Expiratory pause. There we go. So let's try that. We could do an expiratory pause, but we could also do an inspiratory pause, right? What's the difference? Either way, you got 0 flow. And now, having done that, we see no large inspiratory efforts, but we get a perturbation in the flow, not the flow, excuse me, in the pressure signal, because flow is constrained to be 0, so volume has to be constant. We see these changes in pressure about every second or so, but maybe I think it's every half second. So something that happens every half second is much more likely to be a heartbeat than an inspiratory effort, particularly when it's so regular here, right? These are regular intervals. So I think that we would go ahead and say that this is cardiac oscillations, and that's how we would characterize this thing. Any other comments? Anything else we want to talk about here? Turns out that we could have used another slide for this.
Something I would like to remark, Rob, if we have the time, that those cardiogenic oscillations can cause auto-triggering more frequently when the triggering variable is flow compared to pressure. So most of the time on, especially in the servo use, flow of 1.6, 1.8 could be prone to auto-triggering versus pressure of minus 1.5.
Yep, exactly. So what you're pointing out is that flow triggering is intrinsically more sensitive than pressure triggering, right? And there's less work to trigger. And so when you have that kind of problem, Ari, do you find that switching from flow triggering to pressure triggering gets rid of the problem?
No, but it let me unmask sometimes auto-triggering costs due to cardiogenic oscillations besides the fact that I always try to make an expiratory pause to confirm if the patient is really triggering, or it could be something else.
Well, suppose they were auto-triggering with an expiratory, because of cardiac oscillations, how do you handle that clinically?
If during the pause there's no evidence of PMAS, I switch the pressure, the triggering variable to pressure, sometimes -1.5 to the most, but being sure there is no PMAS activity. Otherwise, if the patient is coming back from sedatives, it's going to be really harder for him or her to trigger after. But the main goal is to identify the cardiogenic oscillations triggering the false triggering and try to solve it, because gases could be completely different without it.
Right. So we had a question from someone in the audience about this little notch right here, right? What's causing that? Well, you often see notches like that, and sometimes they're very big. Sometimes you see them look like that, right? And that's when you have a high load on the ventilator, either because of a very high resistance or a very low compliance, high elastance. And the fluid and the pressure change so fast that the ventilator is trying to maintain PEEP, and its control system is not perfect. So its control system oftentimes can't handle it, and you will see this sort of oscillations. There's not really any information to be picked up from that. This here and this here. One thing to note, though, is that if this oscillation gets to be big enough, either in the flow signal or the pressure signal, that in itself can cause auto-triggering as well. Ari, have you ever seen that happen?
Yes, frequently on COPD or patients with increased resistance, the elastic recall of the circuit can trigger another breath.
Yep.
And
That's a good point. So anytime you see something that's not smooth like that, you want to think about what's going on, what could be causing that. In this case, it's just noise in the signal. It's not the patient doing anything. Like a water hammer, but vent dynamics. Yeah, I guess that would be what you call it that. Okay, so VentBuster says, my old post about cardiac oscillations, almost 15 to 20 centimeter pressure drop in regular during expiratory and inspiratory pause, but this was efforts.
yeah, sometimes it's very hard to differentiate one from the others, but you need to see the clinical picture. If it is a patient that which is very sedated, it doesn't make sense that he's triggering the vent. When we talk about sensitivity, it's trying to make it less sensitive for the false triggering to occur. I've seen people going to -5, -4 sometimes. But like I said, you have to be very careful because when PMAS appears, the patient is going to be displaying a large efforts to trigger the vent. But it could happen, and it happens very often, and it is one of the most things that confound or can trick the bedside care practitioners by thinking that the patient is triggering when it's not. And that happens sometimes in pressure support also.
It seems to me that cardiac oscillations can cause big changes in airway pressure on patients that have very stiff lungs, right? Because it doesn't take much volume displacement in the airways by the heart to cause a fairly big pressure change. You're not likely to see that with someone with emphysema or COPD or normal lungs. Would you agree with that?
Yes. Sometimes you can observe the neck very bouncing pulses. And like I said, the clinical picture doesn't make sense for the patient to trigger.
Right. Would anybody out there that's a clinician like to comment on whether they like to use a descending ramp waveform for flow and volume control? And if so, know, what you think about it, why you like it?
Um,
I'm curious because I honestly don't know. I
yeah.
just see it happen all the time.
Well, let me ask you something, Rob, because I'm making the same question. I always choose to, when we use volume control, to select the rectangular or what we call the constant flow shape for several reasons. First, because we can see the stress index, which give us a rough idea about if we are distending, over distending, or we can titrate the PEEP also. And the fact that we select machines with the same eye time when we switch from the constant to the descending ramp, the peak inspiratory flow doubles, which to me makes we introduce more 3/4 of the tidal volume in half of the eye time versus the rectangular that inserts half of it. Some people say that since you introduce more tidal volume in less time, you can increase the mean airway pressure or the time available for oxygenation. Honestly, I would love to make a study about that, but I'm highly favor the rectangular flow shape.
That if we go back to the beginning, the idea that a descending ramp will give you a higher mean airway pressure is true. And the reason is, if you will recall, if you have a constant flow, then you're going to get a waveform that looks more like that, more like a triangle than a square or a little hump like that. So if you will recall, mean airway pressure is proportional to the area under the curve, the whole expiratory period, all of this. So if you increase the area under the inspiratory portion, then you're going to increase mean airway pressure. You're also going to keep the airways open longer during inspiration. And if you have a patient that's recruiting all the way through, then that could improve oxygenation as well. On the other hand, you might not want to have a higher mean airway pressure for the same level of ventilation, for the same level of CO2, because if you have a patient that has a low cardiac output and is hemodynamically unstable, then that's probably not a good thing. There are some ventilators that will allow you to do a sinusoidal waveform like that for inspiratory flow. Not all of them have that. And you could argue that is more physiologic, but I don't know of any evidence that says that that really has any bearing on outcome. Okay. Any other comments by anybody? All right then, well, I think we're going to conclude a little bit early today. I thank you all for joining us, and I'm going to share my screen again so that you can see the CRCEs and also your QR code for your prior episodes. These are our emails. If you want to submit waveforms to us, we're always happy to get those. And please let us know how you like this vent rounds, if there's anything we can do to make it more engaging or more educational. So any other comments, Ari?
Not so far. Some people saying that they prefer the constant flow waveform.
Yeah, very cool.
Something else to remark, Rob, is that if we use the same eye time, we're going to be pushing the same tidal volume. So in a few words, it's going to be the same strain. So different flow shapes can give us different strain rates. Since we introduce a higher or lower tidal volume along the inspiratory time. But the
Yeah,
total
that's a good
strain
point.
is
Yeah,
going to be the
the
same.
strain rate has been most recently talked about by researchers like Marini. They've actually talked about intratidal power waveforms. So turns out that volume control with a constant flow transfers the least amount of power during inspiration of all the flow waveforms. So it's versus volume control, the descending ramp, or pressure control with any kind of waveform. So yeah, so strain rate is an interesting thing. Power transfer is an interesting thing. We believe that those are all related to ventilator-induced lung injury, but we don't have much clinical data to prove that yet.
And the other thing I have observed in people that use a constant flow shape, especially in the servo I, servo U, that they can, with the capacity to what they call the inspiratory flow retard, you can increase the ascending, the angle of ascending to the peak flow and make it go slower. And most people are still not clear because they do that, but they seem to favor that the initial increase in peak flow gonna generate less airway resistance. But we lose the shape of the stress index by doing that.
Yeah, I agree with that. I don't see any good reason for fiddling around with the inspiratory rise time, either for pressure or for flow. That's a subtle point, and you could argue that the slower rise and flow, it creates less turbulence, but what difference does it make? It's not as if the patient's doing any work. The ventilator's doing all the work during inspiration. So my advice to people is to leave it alone. Let the rise time be as short as possible so you can get the stress index and you can make better estimates of compliance and resistance.
Yeah. At the end of the day, the only pressure reaching the lung is the elastic component. The resistive components is going to be wasted on the airways.
Exactly. So the difference between peak pressure and plateau pressure is irrelevant. Any pressure spikes that you might see in the waveform during inspiration, irrelevant. They don't reach the lungs. Good point. All right. So with that, I think we're going to close just about on time. I thank you all for joining us, and I will see you next time.